You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 16th, 2024. This week, diuretic therapy in heart failure, AF ablation, TACT2 and the story of subgroups, and SGLT2 inhibitor underuse. The first topic today is about acute heart failure therapy. The European Heart Journal has published a small RCT randomized controlled trial comparing the use of dapagliflozin versus metalazone in patients with HFrEF, heart failure with reduced ejection fraction, and resistance to loop diuretics. It's an important topic and one that comes up often. I have a low threshold for using metalazone because it works so well, sometimes too well in fact. You really have to watch for severe hypokalemia and volume depletion. A few years ago, the New England Journal of Medicine published the ADVOR trial of acetazolamide versus placebo added to loop diuretics in patients with heart failure. Acetazolamide, a carbonic anhydrous inhibitor that reduces proximal tubular sodium reabsorption, it did improve the primary endpoint of successful decongestion, defined as the absence of signs of volume overload and without an indication for escalation of decongestive therapy. Now, I haven't seen much acetazolamide used. Maybe you all use it. I don't think many of us are that familiar with it, at least here. The European Heart Journal trial comparing DAPA to metalazone is a bit different in that it studies patients who don't diurese well with initial loop diuretics. Now, dapagliflozin does have the advantage of being one of the four pillars of GDMT, so if it aided diuresis in diuretic-resistant patients, who, by virtue of their resistance, are probably sicker, it would certainly simplify the heart failure treatment pathway because you have already started one of the four pillars with the dapagliflozin. So the Glasgow, Scotland team led the trial. First author, Sue Earn-Yo. This was a short trial. Patients received either DAPA or metalazone in open-label fashion. It was a 3-day treatment period with a follow-up for primary endpoint at 5 days. The primary endpoint was diuretic effect assessed by change in body weight. It's a good primary endpoint. Secondary endpoints were change in pulmonary congestion, assessed by lung ultrasound, which is interesting, loop diuretic efficiency, which is the weight change per 40 milligrams of furosemide, and also a volume assessment score. 61 patients were randomized, but remember, when you see that 61 patients, we're not looking at a binary primary outcome. We're looking at a change in weight, which is a continuous outcome. So you don't need as many patients. And the classic example here, this is sort of an aside, is the Orbita trial, which was the sham-controlled trial of PCI. Now, when the results of Orbita showed no significant change in exercise time with PCI over sham, many criticized the study for being small, only 100 patients per arm. But Rasha Al-Lawmi and Daryl Francis taught us all that the trial was actually overpowered because they were looking not at a binary yes-no event that we're so used to in cardiology, but a continuous event like exercise time. Well, it's the same here in this trial with weight. In this trial, patients in both the DAPA and metalazone arm lost weight, about 3 kilograms versus 3.6 kilograms. The difference, only 0.65 kilograms, did not meet statistical significance. In other words, both drugs worked. As for the secondary endpoints, none were significantly different, though the dose of furosemide per kilogram was a bit higher with dapagliflozin than metalazone, suggesting slightly higher diuretic efficiency in the metalazone arm. There were no significant differences in adverse events between the two drugs, although a higher proportion of patients treated with metalazone experienced symptoms of hypotension and volume depletion compared to those treated with dapagliflozin. My comments. I really like this effort in this trial. As I've said many times on this podcast, RCTs are the best way to know things. Here was a pragmatic trial of two common strategies for treating patients with congestion due to LV dysfunction. DAPA held its own against the big gun of metalazone. Though it didn't quite have the diuretic efficiency of metalazone, the primary endpoint of weight change was not significantly different. So, on the one hand, this trial shows that SGLT2 inhibitors surely aid in the decongestion of patients with HFrEF, and since SGLT2 inhibitors are one of the 4 pillars, getting it started early may improve the logistics of heart failure management. By the way, the logistics of heart failure care should not be underestimated. It is not always easy to get these 4 drugs going in the real world. In the real world, for instance, there are no trial coordinators to help us do this. But on the other hand, SGLT2 inhibitors are quite expensive. Metalazone is not. If you felt a patient was not likely to be taking SGLT2 inhibitors long-term, say because of cost, then DAPA is a far more costly way to achieve diuresis in a loop diuretic-resistant patient. Nonetheless, I say kudos to the team in Glasgow. They have shown us how feasible this sort of thing is. Rather than just treating these patients willy-nilly, per the opinion of a doctor, they randomize patients, and we learn something from that, and this is a very good thing. I will come back to the cost of SGLT2 inhibitors again on this podcast, as there's another good study on the matter. Okay, next though is rapid medicine titration for acute heart failure. I want to say another thing here about hospital pathways for patients with heart failure. The ACC recently updated its expert decision pathway for patients admitted with heart failure. The new document places greater emphasis on getting patients with HFrEF on all 4 pillars of GDMT as early as possible, and I'll link to that new document that's published in JACC. Now, I agree with this sentiment under one specific scenario. Let's take this patient, a youngish male patient who has really good blood pressure, good kidney function, and minimal comorbidity. I say for that patient, go full gas. For the other 95% of HFrEF patients that I see, the process ought to be a little less aggressive and maybe more careful and nuanced. For instance, let's take beta blocker initiation. I think this is one of the biggest mistakes that I see people make. You have a patient with acute decompensation, terrible LV function, and you have these parameters of low output. Poor kidney function, sluggish mentation, failure to thrive. They just look terrible. Their heart isn't pumping well. On paper, to the coders and the graders of healthcare quality, the patient has HFrEF and should be on a beta blocker. But negative onotropy is the last thing these acutely failing hearts needs. What that patient needs is afterload reduction and diuresis. I have no idea why the translation of beta blocker evidence is so cattywampus. These drugs were proven beneficial in stable, ambulatory outpatients, not hospitalized patients with decompensated heart failure who have soft blood pressure. ACE inhibitors, ARNI, MRAs, SGLT2 inhibitors are fine if used at the proper dosages, but let's take a deep breath on use of beta blockers in these patients. Here's another thing you don't see from heart failure docs on Twitter. A lot of heart failure decompensation is due to atrial fibrillation, often with elevated heart rates. If this happens, please, my friends, phone a friend. Call your EP team. We can help. Now, one great thing about the document is that there's a section on palliative care, which is underused. I wish palliative care wasn't the last section, but at least it's in the document. Plus, they have a nice figure laying out the things that palliative care can help with. Hospice referral is only one of the many things. And I've said this before, but it's worth reiterating that if we wanted to emphasize the care part of heart failure care, we would get palliative care involved earlier, not to refer to hospice, but to help with symptom control, family support, advanced care planning, or disagreements between clinicians and patients. The two headwinds I see for using palliative care are A, There are few incentives to get them involved, and B, palliative care doesn't have these advocates. You see docs tweeting about ARNIs, SGLT2 inhibitors, devices, but there are few vocal advocates for palliative care. Instead, we hear about rapid titration of meds. My problem with this whole effort is that having a long and well-illustrated document makes it seem like heart failure care can be put on a protocol. I'm nearly 3 decades into my career, and I don't believe it can. Quality heart failure care requires everything. Knowledge about the drugs and devices, of course, but also the skill to apply the most beneficial and most likely to be tolerated therapies. And, of course, huge doses of caring. All right, now let's talk about SGLT2 inhibitor use in the United States. Jack has published an interesting study on the use of these drugs. First author is Jung M. Shin. Here is the deal. SGLT2 inhibitors have a Class 1A recommendation in heart failure, CKD, diabetes, and the authors sought to sort out SGLT2 inhibitor use in patients with these strongest recommendations. And they use data from the Optum Labs database over 2022 to 2023. So this was more than 3 million patients, and it's contemporary data. They found among patients with diabetes, 63% had a Class 1 recommendation, but only 11% were on the drug. Among non-diabetic patients, 6% had a Class 1 recommendation, only 3% received the SGLT2 inhibitor drugs. They also found that no system had greater than 25% SGLT2 inhibitor prescription rate among people who have these Class 1A recommendations. Though health systems with higher proportions of patients who had commercial insurance and lower proportions with Medicare, of course, had higher usages of SGLT2 inhibitor rates. Now, the editorial for this paper is actually what caught my eye. The editorial is titled Cardiovascular Care in the U.S., Penny Wise and Pound Foolish. Now, this was written by Tariq Ahmed and some colleagues, and the authors write that this is basically woeful underuse of a proven therapy. I like this quote, academic cardiologists find themselves in an ecosystem of bewilderment and frustration. They have penned thousands of manuscripts, delivered numerous talks, posted on social media, all decreeing the underuse of cost-effective and easy-to-administer treatments for the prevention and management of chronic cardiovascular diseases, yet every real-world study on the use of these basic treatments confirms a disheartening reality. Only a minority of eligible patients are prescribed these medications, end quote. Now, that comment makes me smile. Let's just stick with the SGLT2 inhibitors. The most obvious reason for low usage is cost. They note that in their editorial, and they advocate for payment systems, quote, that appropriately value and incentivize provisions of care that drives value, rewards prevention, and prioritizes quality over quantity. Now, that's great, but the trouble that I have is that I have no idea what payment system that would be. I mean, in my clinic here in the middle of America, I have trouble prescribing a simple DOAC, which have been on the market for 10 years. Many of these patients with AFib show up at the pharmacy and get a $500 bill. Now, consider heart failure patients. Many of my colleagues love sacubitril valsartan with its one trial, and that drug is costly. Now they want them to take another expensive medication. Patients can't do this. Now, maybe one of the things we could do to improve SGLT2 inhibitor use is to prescribe ramipril instead of the ARNI drug. But that is not a favored approach, and I don't see that advocated for on Twitter. Of course, I don't have the answer to cost issues in the U.S. Countries like Denmark and Canada, they seem to have it figured out, but we don't. But even without cost constraints, real-world clinicians like me must deal with the issue of evidence translation outside of trials. Okay, in my electronic health record, I get many notifications saying that this patient has a Class 1 indication for something, and I should be using it. But in reality, they have many reasons why that would not work. Say they're frail, or they're low income, or they have comorbid features. Or this one, many patients don't want to take that many pills. Now, I know that the Yale team who wrote this editorial and in charge of Jack think a lot of aligning care with patients' values. Well, many times patients' values don't align with taking all the drugs that we think they should. So I agree that implementation science is definitely an important next frontier in cardiology, but implementation science is going to be hard. And I think that we'll soon discover how much different it is out here in our clinics than it is in the trials or the wealthy academic medical centers with all those trial coordinators. All right, next topic is AF ablation. Should we be using general anesthesia or is conscious sedation enough? Now, AF ablation requires some sort of sedation for two reasons. One is that thermal energy causes pain, and the second is that 3D mapping requires patients to be still so as not to move the map. In the United States, most AF ablation is done with general anesthesia, but in cost-constrained systems, AF ablation is often done with conscious sedation. Obviously, not requiring another doctor makes the ablation less costly. One of the most important factors in successful AF ablation is getting good lesion durability. General anesthesia allows the patients to be still during the lesion. GA also provides smooth, regular tidal volumes. You don't get these big breaths that patients have on conscious sedation. You can even minimize thoracic movement with lower tidal volumes. So a group from the Herlev Gentofte University Hospital in Copenhagen asked the question as to whether either sedation method improved outcomes. The first author is Lise de Ries Vestergaard. Sorry for the mispronunciation. Now, I've had the honor of visiting this lab when I was at the University of Copenhagen earlier this year. Now, the best way to compare these two strategies of GA versus conscious sedation would be an RCT. This group used the second best way. They used the National Danish Registry. And there's a twist here that I'll tell you about later, a twist that makes this a bit of a quasi-randomized trial. The team conducted a study of patients who had first-time AF ablation between 2010 and 2018. Patients were categorized by anesthesia type, general anesthesia or conscious sedation. Their primary endpoint was AF recurrence, which they used a surrogate for. It could be indicated by a receipt of antiarrhythmic drugs, for an AFib-related hospital admission, for cardioversion, or for reablation. They did a correlation analysis to assess the role of anesthesia type on that primary endpoint. They had about 6,400 patients with conscious sedation versus only 1,500 with GA or general anesthesia. RF was more common than cryoballoon. The median age of patients was young at 62 years, mostly men, 70%. Now, there were differences in baseline characteristics. The GA group had more persistent AFib, 50 versus 35%. The GA group had more heart failure, 21 versus 15%. And the GA group had slightly more amiodarone use. As an aside, the diagnosis to ablation time in both groups was about 3.8 years. So Danes do not do willy-nilly ablation like many cowboys here in the United States do after like one or two cases of AFib. The use of GA increased from below 10% to 25 to 35% over the time period. They also noted that the use of conscious sedation or GA varied between the 7 centers, but they found no interaction between the centers and the outcome of interest. Their main result was that recurrent AF was significantly higher in the conscious sedation arm at 1 year. It was 46% versus 37%, and it was the same at 5 years. Here it was 67 versus 63%, and both those differences were statistically significant. They found that the difference in the two arms was most pronounced during the first 4 years. The Kaplan-Meier curves showing higher AF recurrences for conscious sedation were similar in PAF patients or persistent AF patients, though the difference was greater in paroxysmal patients. In other words, general anesthesia outperformed conscious sedation to a higher degree in patients with paroxysmal AFib. The number of reablations was also significantly different, 4% versus 1.8% in the conscious sedation versus GA group. So if you looked at relative risk, the hazard ratio was 1.26, higher rate of AF recurrence in the conscious sedation group. There were no significant differences in procedural complications. Okay, my comments. These results strongly favoring general anesthesia kind of surprised me. Recall that I told you that the GA group were slightly sicker. they had more persistent AFib, more amiodarone, more heart failure. So if there was selection bias, you'd expect them to do a little worse than conscious sedation, but it was the opposite. The general anesthesia group, even though they were sicker, they outperformed despite the sicker patients. After propensity matching, the group found that the hazard ratios were basically the same. In other words, the imbalance of baseline characteristics from this non-randomized comparison study went the opposite way with the results. Now, I guess it is possible that patients selected for GA were better in some other way, not captured in the data, but that seems unlikely. Now, having visited Denmark, I also don't get the sense that GA or conscious sedation was chosen based on patient characteristics, but rather more of availability in the center's workflow, which means that the choice is sort of closer to a quasi-random choice. So given these things, I think it's very possible that GA caused the better results. Now, I know we can't claim causality, but it's plausible, right? Because GA allows for better energy delivery, patients don't move, respiration movement is lessened, and this could plausibly lead to better energy delivery, more durable PVI. Now, the authors in their discussion compare their findings to previous work, most of which includes observational studies, though there are 2 very small RCTs from single centers and very short follow-up. They cited a meta-analysis of observational studies suggesting that GA may reduce the risk of recurrence, but follow-up in that meta-analysis was short at 1 year, and this involved studies done more than a decade ago. To me, I think this is very nice work. It's not an RCT, but it's a strong observational study that I think gets very close to making causal inference. The authors don't tell us about the cost, but the lower rates of recurrence seem to me worth the cost, and a cost efficacy analysis may show even better cost efficacy with GA. The question for the future will be how GA affects pulse field ablation. PFA, the electrical energy, are shocks essentially, and they require some sort of sedation, probably deep sedation with propofol, but most likely GA. Now, the contact and the quality of energy delivery is also an issue for PFA, so I would predict that general anesthesia will also excel in this energy modality. Finally, the Danes are lucky to have such a national treasure in this database because it allows for such excellent evidence generation. Okay, final topic today is the TACT2 trial is published. This week, JAMA published a TACT2 trial of chelation therapy for patients with previous MI and diabetes. Now, before you tune out, there's more here than the story of just chelation. It's a story that really gets to the core of evidence appraisal. Now, chelation, of course, is not a mainstream therapy. Maybe you haven't even heard of it. The idea is to chelate heavy metals, mostly lead and cadmium, so that they can be excreted. Observational studies have associated heavy metals with atherosclerosis and bad outcomes. 11 years ago, Dr. Gervasio Lamas shocked the cardiology world when he presented the TACT1 trial. That trial studied 1,700 patients who had had previous MI, and chelation reduced the incidence of primary composite endpoint of death, MI, stroke, revascularization, or angina by 18% over a placebo chelation. That hazard ratio of 0.82 met statistical significance, but barely. Now, this was a highly controversial trial because much of chelation is done outside of mainstream medicine by alternative medicine practitioners. There were editorials at the time questioning the validity of the trial, and Lamas, though, was and is an established academic researcher. Now, beyond the positive endpoint of TACT1, there was this interesting subgroup finding wherein all the benefit from chelation seemed to occur in patients with diabetes. They subsequently published a subgroup finding in Circ Outcomes a year later in 2014. They had slightly more than a third of the patients in the main trial had diabetes. In these patients, chelation reduced the primary endpoint not by 18%, but by 41%. The confidence intervals that went from 0.44 to 0.79, and a highly significant p-value. And the absolute risk reduction was also substantial. It was 25% versus 38%, so the NNT was like 7 patients. Chelation also reduced all-cause mortality in this subgroup of patients with diabetes. Now think about this. If this were true, It would have been a scientific breakthrough worthy of a Nobel Prize, right? I say that because not only would it have established chelation as a disease-modifying therapy for atherosclerosis, but more importantly, it would have established a heretofore unrecognized cause of vascular disease, and that is heavy metal exposure. Now, that all happened about a decade ago. Now, recall that we always say subgroup analyses are, quote, hypothesis generating. We say that because trials are powered to find a difference in outcomes in the overall group of patients in the trial. But when a subgroup is a small subset and there isn't the power to detect differences, that means in those subgroups you may get false negatives, that is, not seeing an effect that's actually there, or you may see false positives, seeing something big that's just by chance, like the findings of astrological sign in ISIS-2. So Dr. Lamas went to work. He designed and conducted the TACT-2 trial, just in diabetics. Now, we know this from his presentation earlier that TACT-2 was a negative trial. The JAMA paper makes it official. About 950 patients, chelation versus placebo. Outcomes were about 35.6% in both groups. There was no difference, nada. None of the components of the primary endpoint differed. Chelation did reduce blood levels of lead, whereas lead levels remained stable in the placebo group. So despite this lead reduction, EDTA chelation was not effective in reducing major adverse cardiac events. So my comments, as I've said before, this is how medical science done well looks like. Instead of over-promoting a single trial and its strong heterogeneous treatment effect in diabetics, Lamas and his team sought to A, replicate the findings of chelation's benefit, and B, evaluate the subgroup finding. It's notable that in TACT-1, the diabetic subgroup had a massive 41% reduction in MACE, but in TACT-2, it was all zero. To me, this is a good lesson every time we get fired up about a possible subgroup finding. In fact, I think the lessons extend beyond subgroups to the positive trials themselves. The TACT trial teaches us that trials ought to be replicated. Statin drugs have hundreds of trials. We are confident that statins modify atherosclerosis. SGLT2 inhibitors, which I've mentioned on this podcast, have multiple positive trials, so we're confident that they modify disease as well. ACE inhibitors in heart failure are another example. Yet I often go back to sacubitril/valsartan, one trial, all the other trials essentially non-significant. In 2024 and beyond, it's going to be hard to improve on what we do now. Humans, we all have an expiration date. We die at age 85 or 90. And it's increasingly common that heart disease patients live so long that they die of something else. Our successes in cardiology make it even more pertinent to be cautious with positive trials. Replication has always been valuable, but I think it's more valuable in the current era. The TACT2 authors speculate about why the trial of only diabetics came out negative. Maybe it is that lower baseline levels of heavy metal these days, and that's a possibility, but I think equally likely is that the first trial was positive based on chance. And I think it tells us that we should replicate positive trials. So that's it for this week in cardiology. As always, I'm grateful that you listened, and thank you. And if you like this podcast, please take the time, give us a rating, write us a review. If you don't agree with something that I say, go to the website, write a comment. I learn from these. Until next week, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.